Thanks, Lindeen. And we have gotten to work with the Muir Group and Lindeen Brick over the last couple of years. And Lindeen is a lawyer, healthcare lawyer, but also a consultant. And she has just a wonderful niche practice. It's been very helpful to our firm in terms of augmenting and supplementing what we do. And so we're very pleased for the collaboration, and we're very pleased to be here today and to be part of this presentation. I'm the chair of the health system subgroup at Reinhart, and we are going to be presenting on the ACO topic, and then we'll lead into the co-management agreement, which Lindeen and Kyle will talk on, and then we're going to have a great panel this afternoon. And I'd just like to point out the group that we have in this room are people that are just great thinkers. We hope to put together the right people. We've got people from the managed care segment, actuarial world, physician world, and legal, general counsel world, CEO world, and we're really, really pleased with this dynamic. With healthcare reform, and I view it kind of as a movement and a journey. It's so multidimensional that I think all of us are having trouble getting our arms around it. And I think that I've heard from CEOs that I think are very, very well-heeled, and they work through complex situations very carefully, that this is one of the most challenging times in their careers because, and I find this as a health lawyer, there's so much to know, and you can't just know your own discipline, you got to know everybody else's discipline, and you have to figure out how all of these things come together in a sensible manner. And we're all trying to do all this exactly at the same time that nothing, in some respects, nothing's changed. Our payment system is still the same way. We're still fee-for-service. We're still based on units. So we're trying to prepare for change, embrace change, be sensible about change, at the same time that we're trying to make money and do it the way we've traditionally done it, and be sensitive to our bottom lines. So that's the challenge right now. And it's an exciting topic, so thank you all for being here. We intend this day to be participatory. So if you want to interrupt, ask a question, make a comment, have an insight, that's what we're here for today. This is a roundtable type discussion, not a monologue. As I said before, I'm the first presenter. Chris Anderson, and I just want to say I'm really honored to be here with my colleagues today. Chris Anderson, Carolyn Booty, Brian Carroll in the back. We're a kind of a self-appointed group that have a team working on ACO development. And part of, in a professional firm, it's fun to have people around you who are good thinkers and who want to learn and be part of this. So thanks to everybody for being here today. Okay, so getting into topics. My job is to kind of set the stage and talk about ACO development. And I think it's always important when you start with this topic to get yourself oriented. So I'm going to do the best in the time allotted to give you sort of a frame up on ACOs. And it's a complex topic legally, functionally, and financially. So we might not get it all decided and resolved today, but I think the goal here is to get the framework so that we're all speaking on the same in the same language. By way of introduction, let's step back a minute. And I think it's really important when you're thinking about a topic to step back and really determine where you are on the chessboard. I started practicing law in 1984, and it was a time where DRGs just came on the scene. Practiced all through the 90s, and if you recall, that was a time of great activity, and people who have been through the 90s always talk about the 90s in relationship to today, because they say, look, we had that time period where practice group acquisition was the rage. There were the publicly held practice management models that were out there, FICOR and MedPartners, and it was an era of PCP dominance, or perceived PCP dominance. Primary care doctors were hailed as the true drivers of the healthcare system, and the conventional wisdom was that this was going to be, we're going to have great systemic change because PCPs were going to consolidate, and they wield tremendous leverage over the healthcare system, as we know, and that delivery was going to change. And obviously a lot of that failed. The PCP models did not survive. They weren't financially viable. They assumed, there were models that assumed a lot of risk. So we ended up with really a kind of a bust of the whole model of the practice management groups. And so a lot of, and HMOs were also hailed at that time as the new payment system that was going to change the way healthcare worked. And really, it all fell apart, and we went back to how we normally did it. So when you think of healthcare reform and you think about the 1990s, I always like to think, what really happened in the 1990s? What's different now? And what I think happened, and many of you might have more insights on this, was that there were an acquisition of ones and twos. There was a combination of diverse groups. There wasn't a lot of attention to how the doctors were paid. There was a big rush to acquire doctors, no matter what the cost was, both in terms of compensation system and in terms of the practice cost. And there was assumption of risk among diverse professionals that weren't necessarily knitted together in a group. High growth strategies with not a lot of thought behind how the groups actually were going to govern themselves, be paid, and how they were going to deliver care. What worked in the 1990s, in my judgment, when you did see things, and there were very few that actually worked, foundation models, cohesive groups of physicians, strong clinic governance, strong physician input into governance, well-defined compensation systems, commitment to community, and a lot of nonprofits, I think, did better than some of the for-profits, and a commitment to shared governance. Also, a thing that worked quite well, and I think it maybe lays the basis for today, is Medicaid HMOs. I think the decision that many state governments made to get waivers and to have Medicaid HMOs begin to manage that block of business was relatively successful. So what's changed right now, and why do we want to embrace change? Well, first of all, we've got huge budget deficits, and that's both at the state and federal levels. We all know that. We also have, so we know we've got to make a change because of these deficits. We also know that over the last 10 years, the entire industry has been focusing on quality. If you go back to the 1990s, it was before To Err What Is Human was published, before Crossing the Quality Chasm was published. Evidence-based medicine was not something we talked about. I don't know if that term had been coined. So we've had a lot of work. The industry, in a very dedicated manner, has worked very hard over the last 10 years to improve quality. And that change has resulted in pilot programs like the Premier Demonstration Project, where we've actually shown if we deliver care the right way the first time, we save money and we improve quality. So the times have changed. There are different triggers right now than there were in the 1990s that are going to cause us to move and change as an industry. Definitionally, I would just say, when you're talking about, people talk about ACOs all the time. So what is an ACO? And there are kind of two strains of thought on this, and I want to set these out so we kind of get our bearings. If you look in the Congressional Research Service's materials on ACOs, what they say is ACOs are collaborations that integrate groups of providers around the ability to receive shared savings bonuses for Medicare by achieving quality targets and demonstrating savings for a defined group of patients. That's what it is. It's the Medicare Shared Savings Program. So a lot of times people will say Medicare ACOs. So people use the term ACOs in another context, though, and I'm going to quote, this last summer I had the privilege of seeing Ron Williams speak from Aetna, who's the chairman of Aetna, and Ron spoke to a group of healthcare systems, nationwide providers, and the way he defined it is very interesting. He said the ACOs are the incubators for delivery system reform. ACOs create the incentives and programs to ease transition as value purchasing ramps up and fee-for-service ramps down. So that's where I think you get the disconnect in how people use the term ACO. Is it the incubator for reform, or is it the Medicare ACO, where we're going to get regs in January and we're going to know how to put it together, and it's going to be a structure, and it's going to be about receiving Medicaid populations, Medicaid payments, and managing budgets for 5,000 Medicare patients. That's the difference in terms of terminology. So that's the background, and that's really what an ACO, that's to me the kind of the two twin definitions for what ACOs are. We're going to talk about legal obstacles, but we're going to do that in a way that it is not overly legalistic. Suffice it to say, we know how to structure, it can be structured, it's complex, you don't need to know all the details. And we want to focus today, and hopefully we can accomplish this, on what do we need to do? What are the strategies right now that are going to help your business move forward? So let's start by recognizing the current tension in the system. We have a problem. There are no brakes on the escalating costs of healthcare. This year's price increases are predicted to be at 15%. And you know, I was really very attentive during open enrollment this year, and you know, gall darn it, our costs at Reinhart went up 15%. You know, that rate of growth is simply unsustainable. And when you think about it, it affects our economy in so many different ways, because it's not just the private sector or the employers who are paying the 15% extra. It's the government through Medicaid, it's the government through Medicare, and then it's also state and local governments that are paying the teachers and the local employees. You know, our Milwaukee County has a budget deficit itself of $500 million. Most of that is built around benefit costs for state or for local employees. So we've got a problem. And the ACA, the Affordable Care Act, is trying to address that problem and speed payment reforms really from this volume-based or system to quality and cost. So we need to really, we really need to think about the tension in the system and the change that's trying to be triggered by the Affordable Care Act. You know, how the insurance markets are working, how do we get consumers to change the way they're buying health insurance, you know, how the state health insurance exchanges are going to work in this equation to incentivize reasonable purchasing choice. You know, how are we going to develop tiered benefit design to fit into those state exchanges? And you know, really, how are we going to remodel healthcare so that it works for the country and for our economy? And it can't just work, and in this regard, it can't just work for the insurers and the providers. And that's a point that our friend Ron Williams made when he spoke in August. You know, when you look at it as an industry, we tend to think about, well, the insurance dollar, and we tend to think about, or the dollar, the healthcare dollar, and we tend to think about the tension between the insurers and the providers. You know, and you have the employers saying, yeah, but what about us? And the actual consumers, people like me who have to buy health insurance, what about us? How do we share in the savings? Once everybody decides what their role is and how much is going to be saved, how does the consumer benefit from that enhanced efficiency? And what we heard, and I think was really interesting over the last, you know, several months, insurers viewing the health system as the way that they take costs out of the system. You know, how do we make the healthcare providers be more efficient? Can we buy hospital beds on the spot market and really make the hospitals not as much able to take as much of the healthcare dollar as they have in the past? And then we have the hospitals sort of erupting and saying, my gosh, we have spent billions and billions as an industry on electronic medical record and care coordination and in voluntary efforts to adapt how we're doing business. You know, we don't need the insurers. The insurers are simply claims processors, and by the way, we can figure out the medical loss ratio. We can do everything they can do. Let's move away from the insurers as the drivers behind the system. So you've got that, in my mind, tension going on. So what are the regulators saying? And I think this quote from Kathleen Sebelius is really interesting. Dysfunctional incentives create fragmentation and fail to address the underlying drivers of disease. In addition, too many decisions are now in the hands of insurance companies, not doctors and patients. So you see that distrust. You see that distrust of the health insurers. Side comment, Rod Williams, when he spoke to our group, was asked directly by one of the healthcare systems, you know, do you intend to buy primary care physician groups? Do you intend to buy IPAs? And I wrote it down and I put it in quotes. Not in scope today, but won't take anything off the table. So, you know, he went on to describe Aetna's key business functions, and one of them, which was right at the top of the list, was business management of healthcare information. And Aetna right now, working with IBM, I'm sure many in the room know some of this better than I do, working with IBM to build a data suite in collaboration with providers, I think maybe more so doctors than health systems, experiments and pilots with the Sharp Clinic in California. And it's kind of based on this IBM cloud computing combined with their Get Active clinical support system, trying to put the medical record with the claims data in a PDA handheld so that primary care physicians can be deployed to save the world and save costs and make sure that patients get good care at the right price. And obviously that framework where hospitals are kind of left behind, where beds are purchased when necessary, is not a happy result for the industry. So then Don Berwick, maybe you all know this, but he was the president of the IHI. I don't know if you know that. So he was the architect, in addition to all the other things he's done, he was the architect of the 100,000 Lives campaign, which I think is really interesting in terms of his focus on quality and improving the industry. The word that he uses all the time is fragmented. I mean, everything you read about him is a fragmented, and the enemy is fragmentation. We just don't seem to form coalitions, the communities we need to make progress. So, in my world, fragmentation is his watchword, which to me is sort of the opposite of single, which leads into the concept of potentially single payer system. 2008 quote from Dr. Berwick: "Simplest way to fix the system is a single-payer system, hiring an integrator with prospective global budgets to take care of a patient population without permission to exclude anyone." I think that's interesting. I think we all think he's thinking single-payer, but what I liked, or what I thought was instructive about the quote is this idea of the integrator. And, I've challenged some of our health system clients. You are the integrator. Be the integrator. Maybe that requires changing the business model, but what, and I'm a health system lawyer, so that's the framework I come from, is how do you as the health system, and I think especially here in Illinois where you guys have CON and oftentimes you are the community provider, or maybe there's one other hospital, how do you become the integrator? How do you change your business model to become the integrator?